what they learned. Cool. So let's just hang back, relax. And if you can turn your video on, please do it. It makes it so much more engaging for those of us who are blabbing away. Thank you. Thank you, David. Thank you, Caitlin. Thank you, Tom. Caitlin, Tom, I don't think I've met you guys. Caitlin, can you tell us a little bit more about yourself?
Yeah, sure. I'm a fourth year med student at VCU, applying into internal medicine.
Incredible. Incredible. How are you applying this year?
Yep. Currently in the interview process.
Oh gosh, how's that going?
It's going. Yeah, no, it's very different being all on Zoom, you know.
True that. You become a Zoom pro. So occasionally I think we all forget to hit the unmute button here or there, but it's really nice to meet you and good luck with the interview process.
Thanks. Nice to meet you too. Happy to be here.
And thanks for joining us. Tom, what's up?
Hey everyone. I'm a second year medical student at in New York City at Columbia.
Nice. Welcome, Tom.
Yeah. I've been a long time podcast listener, but I've started joining the calls the last few days. It's been really fun.
Yeah, I love it. It's so nice to see you and hopefully get to know you better through VMR.
Yeah, me too. You.
Awesome. I see Michael is here too. Michael, what's up?
Hello.
How are you? Can you tell us a little bit more about yourself?
Sure. You've got a lot of enthusiasm. It's actually it's really nice.
I got to tell you, my ideal day is when I get to run with my dog and then get to do VMR afterwards. So you are getting the peak of my joy in life. So yeah, you will not, if you bump into me at 3 o'clock today, as some people on this call might, I'm usually a little bit less bubbly, but Michael, you get bubbly Robbie today.
Hey, that's
How
great.
are you?
I'm great. Obviously first time doing this.
Is your first time?
Yeah.
Nice. Where are you
I just
joining
heard
us
about
from?
this. Joining us from Birmingham, Alabama. So I'm in the UAB MD PhD program, and I'm in the PhD phase. And so
Nice.
during our PhD phase, they try and keep us clinically, figure out how to use the stethoscope. We lose everything in our 4 years. So this is this is cool. I'm excited to join.
What are you doing your PhD in?
I do machine learning and outcome research with electronic medical records.
Amazing. Oh, that path will take you far for sure. That's really, really cool. Thank you for taking the time to join us in the middle of all that important work. I also see some UCSF folks. Hi, Shraddha. Hi. I can't see who's next to you. Hi.
It's Kira. Hi, I'm sharing her phone.
Hi, Kira. Shraddha and Kira have to suffer through my bubble of enthusiasm this morning because we're working together and they're literally right outside. Thanks for joining, y'all.
Yeah, we really enjoy the bubbly. It's nice.
Okay, good. I'm glad it works out well. All right, Yasmin, you want to kick us off? Take it away.
Of course. So a patient presented to the ED with worsening exertional pain over the last 2 to 3 days. Should I keep going?
I think that's a great place to stop. My service was cutting a little bit, so I'll summarize in case other people, it was also choppy for them. I don't think I caught the age, but what I heard was that this patient is having 2 to 3 days of exertional chest pain. Is that right?
Yes.
Awesome. And do you happen to know the age, Yasmin?
Sorry, a 35-year-old female.
35-year-old female.
Breath, exertional chest pain.
Incredible. Okay, y'all, what are you thinking? Type your thoughts in the chat. Remember, stretch out those fingers, please. All right, Maddie, you want to tell us what you're thinking out loud?
Yeah, so I think with 2 to 3 days of chest pain, I'm putting that in kind of the subacute, almost to acute bucket. And did you say that, can you just repeat the age? I just didn't quite catch that.
35.
Yes.
Okay, 35. Okay. So, CV Silvers on the VMRs, we talk a lot about the 4+2+2 approach for kind of morbid, do not miss causes of chest pain. And, we've learned that in and almost every time you approach chest pain, you really want to rule out a morbid cause, but some other symptom that you maybe want to look out for that would make you kind of even worry even more about the morbid causes of chest pain is shortness of breath. So that's why I was, as we get more information, I want to ask about the presence of shortness of breath, along with other things like, is it worth when they're lying down, leg swelling, things like that.
Absolutely superb. I think that you're anchoring us in the fact that whenever somebody says the word chest pain, you have to think about the life-threatening causes. And on the CP Solvers website, there's a great schema for the 4+2+2 category, which we should certainly review and become more and more familiar with, because no matter what, you're going to have to think about it. And I think that, Maddie, you're teaching us something important, which is to say that no matter what, you have to think about those causes. But there's another separate question, which is, when do they become more likely? You have to still do the work, but you can have your pre-test probability influenced by other data you're getting while you're doing that workup. And the lack of shortness of breath in a patient with chest pain provides you with decent reassurance that you're going to end up with a more benign diagnosis. So you might end up with a diagnosis of zoster or costochondritis or a GERD. The presence of shortness of breath guarantees the presence of a sinister cause, with one exception, and that exception is panic disorder or panic attack. So in this patient already, when we hear shortness of breath and chest pain merged together, we know that the probability of that 4+2+2 workup being productive is actually much higher than it would have been if shortness of breath were not at play. And so you may have previously, as I did, thought that chest pain and shortness of breath were kind of unrelated. They don't really work together. But the fact is that the presence of shortness of breath in a patient with chest pain markedly increases the chance of that case being presented on VMR by Yasmin, because it is sinister and scary. Caitlin, you took it a step further, which I think is awesome, by studying another dimension of it, which is exertional. Do you want to just say that out loud and teach us what you know?
Yeah, I guess when I was hearing exertional, I was thinking that could be angina, could be some component of increased demand on the heart, of the myocardium, and that increased demand could be leading to kind of demand ischemia and symptoms on exertion.
Superb. I have nothing to add to that. That's spot on. And then Bento had a very specific thought, which I think is actually important in this patient. Bento, are you able to unmute? If not, just let me know in the chat so I don't bother you for the rest of this hour.
Okay, can you hear me?
Yeah, loud and clear, my friend.
Okay, I thought about pulmonary hypertension because she's a middle-aged woman.
Beautiful, beautiful.
Something like that.
Yes, I love it. Before we talk about that, Bento, can you tell us where you're calling from?
I'm from Brazil.
Wonderful. Where in Brazil?
From Paraíba.
Paraíba. Wonderful. Amanda's giving you a thumbs up. And by the way, good luck today. Not that your team needs it because they're amazing, but good luck in your game in 2 hours or so.
Thank you.
Of course. Bento, you're bringing up a really good point. Can I ask you all to be transparent with yourself? You don't have to say it out loud. If you hear chest pain and shortness of breath first, and then you find out the patient is 75, and then you hear chest pain and shortness of breath first, and then you hear the patient is 35. What is different between those two scenarios? Take a minute to think about that. That's another key part of this case, which Bento is using it very wisely. Amazing, amazing. Jamil, do you have the ability to unmute? Again, just tell me in the chat if you can't. Otherwise, please let us know.
I think that in an older patient, we can think first about let me think how I can say that.
No problem.
Think about arteriosclerosis,
yes,
like Jamel said in the chat.
Yes.
And in a younger patient, we don't think first about that because she's younger.
Beautiful, beautiful. Jamil just turned his video on. Jamil, let us know. Yeah, hi, it's nice to meet you. Where are you calling from?
I'm calling from India, actually.
Amazing. Where in India?
I'm a practicing physician. Yeah, I'm a practicing physician in India. So I've been trying to log into these sessions, but unfortunately, due to my timings, I couldn't. Today, somehow I managed to get into this session, and I'm
Amazing.
happy to be here.
Not as
Yeah.
happy as I am, as Michael already amply pointed out. It's
Thank
really nice to
Thank
have
you,
you.
thank
Where in India are you
Thank
calling
you.
from?
India, it is Hyderabad. If you had heard Hyderabad,
Amazing.
you might not heard. Yeah.
नहीं यार हिंदी बात करते हैं आप?
Oh, wonderful. That's so nice. Yeah, बहुत अच्छी. आप तो बहुत अच्छी हिंदी बात कर रहे हैं. Very nice. It's very comforting. Yeah.
काफी साल गुजारे हैं इंडिया में तो.
I know. Very nice. Wonderful, wonderful. कहाँ पे थे आप? Okay. Yeah. Oh, Priyanka.
I could talk to you. I could talk to you in Hindi, but I'm afraid that it will sabotage the whole hour, and then all these guys.
Sure. Yeah. That's. Sorry, everybody. We'll continue with the session. Yeah. Please go on.
Yeah. So tell us what you were thinking. You shared some great thoughts about how this patient's young age changes things for you.
Young age brings about actually a sudden event. If it is sudden event, vascular should be on top of the list. That should be again life-threatening, as we were mentioning in the upfront. So arterial dissection is one thing. I mean, that came to my mind because she's a female. Coronary artery dissection. If we are thinking in that way, if you are cardiac if you are going deep into cardiac issues, then valvular regions was my next thing that came to my mind, especially outflow tract obstruction, especially AV outflow tract obstruction like aortic valve pathology, maybe. Then coronary artery disease is always there, as I mentioned. So these were the things, and pulmonary hypertension definitely.
Yeah, sure.
But depends upon the, onset, rate of onset, whether it is a sudden onset and gradual onset, exertional chest pain.
Absolutely superb. Jamil, I think your thoughts are very wise, and I think I'll just take a moment to summarize our thoughts and then move on get more information from me, which is basically that what's the key difference? The key difference is the humble recognition that in a patient with 75 who has any thoracic complaint, the probability of ACS is so high. In fact, if you look at the 4+2+2 mnemonic that we have on the website, and you just filter it by common, ACS is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and then PE and aortic dissection, and then everything else. So it really is very tiered. So the reason that we worry less about patients who are 35 is the probability of acute coronary syndrome drops. But what happens to that space that is now left open for other possibilities? Because the truth is that in patients who are young, there's still a range of possibilities. The pie is still 100%, right? So the key question is what happens to that vacuum that's created by the relative removal of acute coronary syndrome? And I think before we discuss that, you have to really be precise in your thinking because it's a relative drop. There are hereditary diseases that can cause accelerated atherosclerosis that are still fair game. So ACS is not zero, but it's much less. So what takes up that space? And what takes up that space is two polar opposite conditions with polar opposite morbidity and mortality. The range of benign diagnoses goes up in people who are younger, for sure, which is why patients with sinister causes of thoracic complaints who are younger tend to have delays in diagnoses. But there are a number of unique conditions that emerge in this space that only affect people who are younger. And a great example of this is congenital heart disease. It is totally plausible for a patient who's 35 to have their first presentation of coarctation of the aorta, or to have their first presentation of a previously subclinical bicuspid aortic valve. And then you can round out that list and make it much longer. And then the final part is to actually recognize that when we say ACS in older people, what we're saying is ACS due to coronary artery atherosclerosis. As Jamil reminded us, you can get acute coronary syndrome from a whole variety of other mechanisms of blood vessel occlusion, not related to atherosclerosis. And there are 3 or 4 of them that are very important to think about in young patients? And I would say Jamil already mentioned the most important one, coronary artery dissection. It's called spontaneous coronary artery dissection, SCAD, to emphasize that it can occur as part of trauma or as part of cardiac catheterization. So SCAD occurs in 1/3 of patients for no good reason, but in the other 2/3 of patients, either as a peripartum or postpartum event, or as a result of, as Ravi just pointed out, fibromuscular dysplasia. So that's one. The other is vasospasm, coronary vasospasm. The third is coronary thrombosis from APLS, polycythemia vera, and then coronary embolism from endocarditis as an example. Those 4 things are lumped into the term MINOCA, which is becoming increasingly used to capture these terms. It is myocardial infarction, MI, with non-obstructive coronary disease, meaning that there's no atherosclerosis, but the patient still had an MI. So to summarize, I think that when we hear that this patient is having chest pain, we got to do 4 + 2 + 2. Maddie reminded us that the presence of shortness of breath increases the probability of that actually taking us to the answer. And then we use the fact that this patient is young to remind us that the probability of something benign is increased, but the probability of an atypical cause of ACS, i.e. MINOCA, has also gone up. And so I think we really got to scrutinize the history for any evidence of those things. And those things would be a smoking history or vasoactive medications to suggest vasospasm, a history of pregnancy, or a history of clues to suggest fibromuscular dysplasia, of which abrupt severe hypertension because of the renal involvement would be a clue. And then hit risk factors for endocarditis and risk factors for hypercoagulable condition. So you got to pay really close attention to this case and not make the mistake that unfortunately happens to these patients where their symptoms are minimized simply because of their age. All right, Yasmin, tell us more.
Okay, so this patient with shortness of breath also complains of headache. Well, before we go on, she has had this intermittent left side chest pain that is worse with exertion and non-reproducible to palpation and deep breathing. She reported that the headache is holocranial and without a specific focal neurological deficit, but does feel slightly confused. She also feels confused. As a note, she had a recent diarrheal illness about 1 week ago with associated nausea, vomiting, and non-bloody diarrhea, along with a positive suprapubic and epigastric pain. These symptoms have now resolved. She also noted a rash in her bilateral upper extremities and bluish discoloration of fingers. Should I go on?
Oh my gosh, what did you just do? Woo!
I was going, yeah, you're in for a ride.
Oh, very interesting history. So do you want to just summarize the key pieces that stuck with you, Yasmin? What do you think is relevant for us to review?
Because she started having this, she also had lower back. This is not the aliquot, but I think that for reasons, okay. She started having lower back and right hip pain and non-specific body aches, as well as diffuse weakness for a few days. Increased urinary frequency, denies fever, night sweats, denies hematemesis, melena, hematochezia, hematuria, dysuria. From my peripheric vision, I can see the chat going crazy. And the thing is, for me, the thing that that started going like a red flag is the right hip pain, the lower back pain, this rash on her bilateral upper extremities, and this recent diarrheal illness, this past history of diarrheal illness, and this chest pain. The pain and the rash, I would still look for if she has past medical history, which she had. You know how Human DX, the app, starts like uncovering more aliquots as you start thinking. And do you want more history?
Yeah, why don't you give us some past medical history?
Past medical history, and where is this? This is coming like more interesting. She has a past medical history of antiphospholipid syndrome. She has had 3 miscarriages, chronic thrombocytopenia, mood disorder, substance use disorder. She used meth occasionally. She also uses tobacco, and she has had interrupted dosing of subcutaneous Lovenox menstruation. She was on warfarin in the past, and she doesn't use immunosuppression. And she also uses Lexapro. She's on Lexapro 10 milligrams, Prilosec 40 milligrams, no past surgeries, no allergies, and family history not known.
Amazing. Oh my gosh. So I'll summarize. We learned that this patient who's having chest pain and shortness of breath has had a complex symptomatology ranging from head to toe, including headaches, abdominal symptoms, recent diarrheal illness, hip pain, back pain. And we learned that the context of her prior medical care has been this diagnosis of APLS with intermittent adherence to her anticoagulation, along with an undescribed substance use disorder with methamphetamine, though we don't know the route and the nature and the frequency. So Hans, your thoughts started to jump to a specific domain. Do you want to share those out loud?
When I heard back pain, hip pain, then I thought maybe the chest pain is more or less skeletal, affecting the like a chondroid, an inflammation of the tendons or the cartilage in the chest, which of course is being more exerted while she's running. So I was thinking about a rheumatological disorder as well, but at the same time, she has a coagulation problem, but this might not be true. It could be that her anticardiolipin finding is related to something like lupus or a similar or related rheumatological problem that we might probably be able to find out through serology, but let's see. And of course, yeah.
Yeah, I think that's absolutely perfect. Thank you for sharing those thoughts. You know, people have complicated feelings about cold calling. I actually think it's a wonderful thing because it sends a strong and important message that there is no wrong or right thought. And so I'm going to do that. And I'm going to lean on my new MS2 friend, Tom. Tom, where does your head go? What did you start thinking?
To be honest, my head was that I sort of was a little overwhelmed with all.
Yeah, right.
I'm still in my organ system education, and so integrating all of this is sort of the next big thing.
Yeah, it's literally impossible, by the way. And the reason I actually asked you to say that is because I want you to know that it's everybody's head went spinning.
Yeah.
And I think it's because when you start to see these patients who have chest pain, it's very unusual that their story involves anything apart from the chest.
Yes.
In fact, the chest pain is so devastating that the entire focus of the presentation is about their chest. And the fact that these things are coming up is relatively unusual. And all of us are kind of in a tailspin right now. So unfortunately, this feeling that you have right now will not go away next year or the year after. It's here to stay. In general, the first thing that you should make sure the patient is not dealing with when you have chest pain plus symptoms outside the thorax is a connection between these things by the plumbing. And what is the most morbid systemic disease that causes chest pain? It's an aortic dissection, as the aorta courses from head to toe. So that would be my first priority in this case. But as Jamil pointed out, the chronology of these symptoms and the fact that they're so separated by time makes that a possibility less likely. So Jamil, what did the chronology do for you in this case?
The basic priority in such case where patient has got so many symptoms, our priority should be to counter the life-threatening, to anticipate the life-threatening possibilities that can happen to this patient should be our priority. So when we are confronted with multiple symptoms, so which symptom came first gives us an idea of the vessels involved probably. As in this case, we are, my first thought was vasculitis because of multiple organ involvement. So vessel involvement was my first thought. And depending upon the chronology of the symptoms where we are looking into, so we can get an idea of clinically, at least clinically, we can get an idea of small vessel vasculitis, medium, as we categorize the patient into. Thereby, we can anticipate now the patient has come to us with the symptom of chest pain. So if we are thinking in terms of a large cell or giant cell arteritis of that sort, so we may anticipate more severe complications. And in the same way, coronary artery dissection, as I was pointing to, it might be a part of a medium, vasculitis, medium-sized vessel vasculitis rather than small vessel vasculitis. So that should have been my priority of chronology of by saying chronology of symptoms, what I meant to.
I love it. I think that's absolutely superb. At the end of this day, whenever you're getting multi-organ disease manifestations in somebody with chest pain, the chest pain makes you think vascular, and the multi-organ dimension makes you think multi-organ vascular issues. And a simple way of simplifying that is to say that the aorta is involved and its branches, or you have a multi-vessel disease like a vasculopathy, fibromuscular dysplasia, or a vasculitis. The truth is, we're never having these conversations in patients who have chest pain because these considerations are exceedingly rare, but they're elevated in this patient by her medical history. She has antiphospholipid antibody syndrome. And that in patients who have variable adherence to the medication can present in catastrophic form and cause what's called catastrophic APLS. But we have to be careful, team. Just because somebody's at risk for a rare disease does not make it likely that she has a complication of said rare disease before us. We have to be open to the regular old things that we would otherwise consider being equally, if not more likely to happen. So with that, I think we should hold this medical history with the right space that it deserves. It deserves to elevate some things, but it does not deserve to distract us from the typical workup and the typical things we do. So let's go ahead and lean on Yasmin to tell us that information as we hold those two things, common things being common, but this patient has reasons for us to not think of those things because of the rarity of her medical history. All right, Yasmin, tell us more.
Yeah, so for the vitals, the temperature, 98.2 Fahrenheit. Sorry, I don't have the Celsius for all the peeps, international peeps. Heart rate 93, respiratory rate 12, blood pressure 118/79, saturation 9. She was mildly anxious, lethargic, normal. The cardiac, we find harsh holosystolic murmur at the 5th left intercostal space. It was a new murmur. There were diminished breath sounds, but otherwise clear and symmetric breath sounds. There was a tenderness in the right upper and lower quadrants in suprapubic region, negative rebound, guarding, rigidity, and normal bowel sounds. There was mild confusion as to why she was in the hospital and to medication she takes. There was no motor or sensory deficits. There was in the skin, blue and purplish discoloration noted in distal phalanges or of upper extremities with nail clubbing. Some edema in the lower extremities, predominantly below ankles, more in the right than in the left. Livido reticularis on the upper extremities and pulses throughout. In the musculoskeletal, there was pain with active flexion of the right hip. Should I go on to the labs?
Yasmin, I think this exam is actually very informative, so let's spend 2 minutes on this exam.
Okay.
My friend Amanda, I discussed with you yesterday, and now I'm addicted. What are you thinking?
Oh my God, I'm thinking a lot of things because it's a very crazy exam. But I'm not for sure. But I think there are cardiac involvement with these exams, and abdominal too. It's just.
I love it. I think you have a rare combination of both cardiac and abdominal findings. David, can you, I'd love to learn from you, especially on Twitter. What are you thinking of this case?
I don't know. I think it must be a systemic organ dysfunction. So I'm going towards a vascular issue, maybe, yeah, maybe catastrophic APLS, other vasculitis, or anything similar, because I think there's too much affection, I mean, in a lot of organs, particularly liver reticularis, these bluish fingers, and I think the vascular system has to be affected. So I don't know.
It's funny you end that with "you don't know," because I think you hit the nail on the head. Are you rooting for Spain? I imagine you're rooting for Spain, but I'm not sure.
Yeah.
Congratulations on your very narrow escape into the final rounds. It's very close.
Yeah.
Are you still in Madrid, or are you somewhere else now?
No, in Madrid, yeah.
Still in Madrid. Amazing. Well, your thoughts are spot on, my friend. You really, I think you were teaching us something very simple, but actually very complicated, which is whenever a patient has multi-organ disease, the simplest way to connect the dots is the fact that there is one organ system that penetrates every organ, and that's the vascular system. And so here, the evidence for the vascular system is monumental. It is the fact that you hear a murmur in the vascular system. It's the fact that you see that the vascular system is literally changed in the form of levator reticularis. If you don't know what that is, you should totally Google it really quickly. It refers to a superficial blood vessel dilation in the skin as a result of proximal occlusion. So the vessels behind those levados are usually tiny and clamped down, and the result is that the superficial vessels above them are dilated. That is a feature of the vasculopathy that occurs in patients with APLS. You also see evidence of vascular compromise in the legs in the form of lower extremity edema, which may map onto a cardiovascular hypothesis. I think the key finding in this case is a ridiculously loud murmur, 5 out of 6, right? 5 out of 6. And as Hans taught us, it's in the mitral region. So I think we can confidently say as a working hypothesis that this patient has mitral regurgitation. Why? There's a murmur in the mitral region, and it's in the systolic phase. In fact, it's holosystolic. So I guess our question is, what causes mitral regurgitation? And I'll just speed us along to say, hey, in a patient with any substance use disorder that could be injected, including meth, it could be, we have to prioritize endocarditis. That's the priority here. So could this patient have endocarditis causing heart failure resulting in lower extremity edema, causing embolic phenomena to the abdomen, to the liver, to the spleen, maybe with the right upper quadrant, left lower quadrant pain? Could that have been the diarrhea? And the reason to prioritize endocarditis is very morbid and potentially lethal. However, remember how we talked about that this patient has common things, infectious endocarditis in a patient with a substance use disorder, but how we have to hold in the possibility that you could have something rare. And what's the rare competing hypothesis? The rare competing hypothesis is this is a complication of APLS. And APLS can cause what's called Liebman-Sachs endocarditis. It is a form of sterile endocarditis that disproportionately affects the mitral valve. And there are clues that we can pick up on to diagnose that, but that's the alternate possibility. So the next step in this patient is to get blood cultures, but in the emergency room, if you're taking care of this patient, you assume that she has endocarditis until proven otherwise, and institute empiric therapy, which would be vancomycin and ceftriaxone. That's your empiric therapy for endocarditis. Now, there's one piece of data that breaks the symmetry a little bit. Culture negative endocarditis, of which APLS is an example, does not usually cause MSK complications. So the fact that her hip is involved makes me worry that she has left or right hip septic arthritis, further increasing the probability that she has endocarditis. However, there's an equally likely competing hypothesis under the APLS umbrella. Do any of you know how APLS can cause right hip pain? It's a fun fact to file in your back pocket because it, for some reason, is frequently tested on board exams. I don't know why. Anyone know? All right, let me tell you. APLS is one rare but well-described cause of avascular necrosis or osteonecrosis. And so we have two hypotheses, infective endocarditis or Liebman-Sachs endocarditis. Infective is more common, more morbid, and as a result, are actionable hypothesis. However, the libido that she has and the clubbing that she has point to a more subacute to chronic condition. And the fact that she's not taking her medications at a decent enough level should have us also holding Liebman-Sachs in our back pocket. All right, Yasmin, enlighten us. What happens next?
So for the labs, her white blood cells were 9.4. Her hemoglobin was 6.4. Hematocrit 20. Her platelets 85. INR 1.1 were 12. PT was 68.3. Mind normal is from 22 to 36. It was very much high or prolonged. And her iron saturation was 68. The normal is 15 to 46%. Her sodium was 133. Her potassium 3.4. Chloride 97. Bicarbonate 21. BUN 49. Creatinine 3.7. with reported baseline around 1.2. Calcium 8.6. Magnesium 2.2. Glucose 100. Albumin 3.3. Total protein 7. Alk-Phos 106. Bilirubin, total bilirubin 0.4. AST 50. ALT 52. The urinalysis, we have it available. Do you want it?
Please.
Okay, so it was positive for white blood cells, more than 100. RBCs from 30 to 50. Mind you, the normal is from 0 to 2 per the, I don't know how you say it in English, by the por campo, I don't know how to say that in English, but it was from 30 to 50, so it was very positive. Epithelial 30 to 50. Protein negative, few bacteria. It was positive for amphetamine. Troponin 5032. BNP. That's not from the parenthesis. Troponin peak 5032. BNP 790. Ferritin 19. CRP 7. They also run a test for a viral COVID, influenza, and RSV. And we also have an, you want it?
Yes, please.
Well, sinus tachycardia, no ST elevation, non-specific ST changes. We also have an additional labs. Should I give it?
Yeah, why don't you take us to, do you have the blood culture results? I think that's the key thing, just to try to end a little early so we can have the team.
The doctors were thinking about LDH 738, 270, fibrinogen more than 700, collagen degradation products more than 20, D-dimer 4,487. Adams 13 within the normal range.
Yeah.
Negative. B12 773 within the normal ranges. B9 14.6, it is elevated. They also have imaging.
Oh my gosh, they got all the tests possible in the hospital. Huh?
Okay, yes, they got everything.
Maybe I can try to explain why I think they got these tests, and then you can tell us the imaging, and then we'll learn together. So yeah, I think David, you said it. David, do you want to explain why they were working up this entity?
Well, the most remarkable labs for me are the anemia, thrombocytopenia, and well, LDH, aptoglobin, the UA. All of these are compatible with hemolytic anemia, and more concretely, I think actinium, traumatic microangiopathy. I don't know if with that diarrhea you can think of is, how do you say in English, HIUS, that hemolytic, uremic hemolytic syndrome, but maybe also with that confusion that the patient is presenting with PTT, or how do you say, and I don't know also if the APLS has something to do with all of these, because maybe well, I think there's a kind of overlap between these entities.
Yeah.
Not sure which is the precise diagnosis, but I think must be in this range.
Amazing. I think that you picked up on all the pertinent lab abnormalities and came to an important conclusion. You saw evidence, you saw an anemia, and you saw that the LDH is high and the haptoglobin is low, and made the diagnosis of hemolytic anemia. And then you saw the platelets are also low, which made you worry that the patient has a microangiopathic hemolytic anemia. And the evidence for that was even higher when you saw that the Coombs, which looks for autoimmune hemolytic anemia, was negative. So this patient very likely has a MAHA, microangiopathic hemolytic anemia. However, before you diagnose a microangiopathic hemolytic anemia, you have to rule out a macroangiopathic hemolytic anemia. What does that mean, this term? It means that red blood cells are destroyed as they course through the journey of a blood vessel, bumping into things that should not be there. And the most common thing that they bump into that should not be there are called microangiopathic, because it's small, tiny clots in the vessels. However, the same process can occur if you have something that is macroscopic, i.e. visible to the naked eye in the blood vessels. A great example of that is the rate of macroangiopathic hemolytic anemia in patients with an intra-aortic balloon pump. You almost expect them to have anemia and thrombocytopenia. Now, what could be causing a macroangiopathic hemolytic anemia in this patient? It's the whopping mitral regurgitation that she is having. So I think that David, you took us to the world of MAHA, and the question is it micro or macro? And I think the macro hypothesis deserves our attention, because the most common and morbid cause of a micro TTP has been made much less likely with the Adams TS13, and the probability of missing endocarditis or Liebman-Sachs as the cause of this mitral regurg looms very large. So in your approach to angiopathic hemolytic anemia, micro versus macro, and when you hear a murmur, you have to make sure it's not macro. All right, we're almost out of time. So Yasmin, do you want to just take us right before the diagnosis is revealed so we can think together?
Of course. So as the chat has been saying, yes, she has a TTE. We found moderate thickness and posterior leaflets involving the leaflet margin more than the base, transvalvular range, nose stenosis. There was a severe regurgitation, and this effective regurgitant orifice 0.6 centimeters. Flow reverse PV Doppler phrasing. In the left valve, moderately increased cavity, left ventricle, sorry, moderately increased cavity size. There was a wall thickness at upper limits of normal systolic function, estimated ejection fraction of 65%. There was a normal wall motion, no regional abnormalities. There was a 2 diastolic dysfunction, pulmonary artery severely increased systolic pressure, estimated at 92 millimeters of mercury. CT, a chest, CT, abdomen, and pelvis, arterial and venous duplex study without notable abnormalities. Blood smear also, reticulocytes and 3%, reticulocyte index at 1.53. The polyhypochromasia, anisopoikilocytosis, occasional schistocytes, morphology and distribution with decreased platelets. More additional labs. We had stool, urine blood cultures negative, Shiga toxin negative, HIV negative, hepatitis, HCV antibodies positive, negative otherwise, hepatitis viruses and fibrosis. And they also did a complement. They looked for complement. It was normal C3, C4, negative ANA, anti-DNA antibodies, rheumatoid factor, ANCA, HIT, PF4, anti-glomerular basal membrane antibodies, cryoglobulins also negative, but obviously positive anticardiolipin, anti-beta 2 glycoprotein because she has antiphospholipid syndrome, also known. And oh, by the way, for the person who asked for procalcitonin, we had 6.3 being high, BMP of 1,200, uric acid at 12. Being with diagnosis, should I give you diagnosis?
1 second. Let the team try to guess. Hans, why do you think it's Liebman-Sachs?
I mean, I was just listening to our discussion, and it kind of, with all the explanations, seems to, with everything that we said, explain almost all her symptoms. From the right heart, or the strain on her heart, which gives a high BNP, which then the troponin is very high. Then all the coagulation problems, the possibility of a MAHA, it seems to all fall into place.
Yeah, I absolutely agree with you.
It's not my idea, but it's just beautifully explained earlier.
Yeah, I think that that's right. I think that the elephant in the room is that we don't have the blood cultures yet, and that I have to tell you, my biggest impression in this case is how worried the team was about this case and how many tests they got to take care of her, but also in the same time, in parallel, how if you work on your clinical reasoning, you could be way more efficient and not need as many tests, because the tension was so clear. Is she endocarditis or Liebman-Sachs? And I think that the key test was to get the echo here. And I don't know if you needed all these tests. This is thousands of dollars. It goes to show you how cost-conscious care is intimately related to the strength of your clinical reasoning. And this case is a great demonstration of that. This is not a critique of patient care. These tests are obtained out of the sheer determination to get to an answer, and not for any other purpose. But I think you can see how, with reflection and the work that you all are doing by choosing to be here on your own time, you can make a lot of progress in that. But I would say, Hans, the final thing that I will add, the chat is on this, you need blood cultures, endocarditis versus Liebman-Sachs, is there is a very powerful clue that this patient has Liebman-Sachs on the echo. And that clue is that the involvement of both sides of the valve. In patients with endocarditis, it's usually one side of the valve that's involved. But Liebman-Sachs characteristically causes a diffuse valve thickening and also causes attachments on the atrial and ventricular side of the valve. It's a very telling mark of Liebman-Sachs. So I think you need the blood cultures to be negative, and if they are, I think you can call this Liebman-Sachs endocarditis, the treatment of which is to resume the patient's anticoagulation. You have to be a little bit careful because the confusion may represent a septic aneurysm, or not an, it's not septic, but an aneurysm in her brain that may bleed with anticoagulation. But before we get the answer from Yasmin and conclude, I think it's always important to practice what you learn without what the answer is. The answer is just the end of the journey. So I'll just go in order of people I see on my screen, just people who've talked already. David, what did you learn from this case? You're at the top of my screen, I think, since you just last talked. What are you taking away from this case?
Well, plenty of things. I think that, of course, what you said in the last or the last articles about macroangiobatic hemolytic anemia, I didn't think to that because I wasn't thinking of that. And I liked also that how you explain the skeletal pain. That wasn't I couldn't find a way to explain that, and I like your explanation of it. And well, I think this is a very complex case. I think that your systematic approach to do the things in the right order, that last reflection about not the necessity of not asking for this complex test that we may not need in this case.
Yeah. Thank you for all your participation and your learning. It's so nice. I see David is probably, like, along with Hans and some other people here, the most ever present people on VMR. So thank you. I'll jump to the person I just met. Caitlin, what did you take away from this case?
Yeah, it was a great case. I think one thing would be looking at the age and thinking, okay, this person's younger, so they probably have generally less ACS risk. So that increases the probability of something like a Minoka, which I hadn't heard of before, the MI with non-obstructive coronary arteries. So then using that to kind of pay more attention to whether or not they have risk factors for like fibromuscular dysplasia or endocarditis.
Beautiful. So well said. Thank you for recapping that point that we made much early on. It had the risk of vanishing and being replaced by all these other things. So I appreciate you bringing it up. Tom, what did you learn?
Yeah, I'm thinking about when you see diffuse symptomatology, going to the vasculature and thinking about all the pathology that can go on there, and at least just considering that as a possible linking cause. I'm thinking about the chronology of symptoms as well, and thinking about what physical exam findings would and lab values would show up when and how that fits in with your differential. Yeah, and just considering Minoka as well is something that hadn't really been covered in our training so far, and micro versus macro for Maha is just another different branch point.
Beautiful. Wow, you're a sponge. Someone stuck with you. That's amazing. Michael, what did you learn?
It's a scary case. I can envision being concerned with some type of bacterial involvement given a recreational drug use history and this kind of vascular complications. Like I can see how this could have gone towards a sepsis and septic shock pathway, which is obviously like a disaster. So yeah, I mean, I just learning how to keep your hand off of that lever, because that's kind of where you want to go, was very interesting. I did have a question about final treatment. You said initiate anticoagulation, but is there anything else that needs to be done to get this person kind of back to baseline? And getting back to her chest pain, her exertional chest pain, like, is the ultimate etiology just the thickening of the heart valves?
There's so many great questions. I'll try to rapid fire answer since we're at time. The ultimate mega treatment for APLS is anticoagulation, plasmapheresis, and anti-immunosuppression. Those are the patients who are the sickest who get that trifecta, though most patients will just get anticoagulation. So it's a judgment call based on experts who have much more experience than I about how far along the anticoagulation, plasmapheresis, and immunosuppression you institute for a specific patient. This person is certainly close to as sick as you get from APLS. What is the mechanism of chest pain in patients with APLS who have this condition? There's at least 3 mechanisms. The first is that she could have clots in her pulmonary artery causing pulmonary hypertension and pain from that. She could also have pain from the mitral valve, but she could also be intermittently flicking off pieces of that mitral valve into her coronary circulation, causing acute coronary syndrome. So those are the 3 that I can think of. There may be even more. Natalie, what did you take away?
Oh, so many good teaching points from everyone shared so far. I think the last teaching point really stuck with me, that when you think of endocarditis at a high level, it can be infectious or non-infectious. And in the non-infectious category, Weidman-Sachs is clearly the one we were discussing most here. And one way to distinguish is by looking at kind of the pattern, like what's shown on the valve. So in Weidman-Sachs endocarditis, you get diffuse valve thickening and pathology on both sides of the valve, but infective endocarditis is mainly on one side of the valve. I didn't know that. That was a good learning point.
Amazing. Awesome. All right, Yasmin, take us home. What did the patient ultimately have? And tell us one thing that you learned.
So for this patient, they did a renal biopsy that showed multiple infiltrating the glomeruli, small blood vessels, liver necrosis, and local ischemia. The final diagnosis was thrombotic microangiopathy. I was doing this human solving. I also thought about endocarditis due to the murmur, but they didn't really add it to the final diagnosis. The case resolution showed the renal biopsy revealed a new diagnosis of thrombotic microangiopathy. And what I learned is that they did all this Adam 13, the Shiga toxin, because they were trying if this was primary or secondary. They finally said that it was her antiphospholipid syndrome. What I learned was that these thrombotic microangiopathies are that require urgent intervention, and we shouldn't wait for the test of Adams 13. Delay the decision to initiate treatment with plasma exchange, and we have to do this, as you already mentioned. The refractory or relapsed TTP requires intensification of plasma exchange and immunosuppression medications, and have also for the full pentat for everyone who may read in the literature, pentat, the fever or neurologic impairment, thrombocytopenia, and ascocytes to start treatment, because that only appears in 5% of patients. We are always like bombarded with the fat RN like mnemonic to be like, oh, that's the show, and that's not always the case. So what they did with this patient, they started plasma exchange, but they didn't really about the murmur.
Oh, no worries at all. What an incredible case. Humbling how APLS can cause so much devastation, and humbling to have learned so much along this journey with you all. Thank you for taking the time to hang out, and I hope you all have a wonderful Friday. See you next time.
Thank you so much.
Bye.